Okay, on behalf of Sangeeta Gopal, who's Associate Professor in Cinema Studies at the University of Oregon, and an Interim Director of CSWS, and Bish Sen, who's Associate Professor in the School of Journalism at the University of Oregon, and myself, Arafat Valiani. I'm Associate Professor and Associate Department Head in the Department of History and affiliated to Sociology and Global Health. Welcome to the last of the Conversations About Our World series. The title is Bioethics in the Time of Black Lives Matter, a Black Feminist Perspective. Our speakers today are Yolanda Wilson, who's Associate Professor at Albert Nagy Center for Healthcare Ethics at St. Louis University, and Kamisha Russell, who's Assistant Professor here at the University of Oregon in the Department of Philosophy. I'm going to start off by reading a territorial statement. The University of Oregon is located on the Kalapuya Ilihi, the traditional indigenous homeland of the Kalapuya people. Following treaties between 1851 and 1855, Kalapuya people were dispossessed of their indigenous homeland by the United States government and forcibly removed to the Coast Reservation in Western Oregon. Today, descendants are citizens of the Confederated Tribes of Grand Ronde Community of Oregon and the Confederated Tribes of Siletz Indians of Oregon, and continue to make important contributions in their communities at the University of Oregon and across the land we now refer to as Oregon. The University of Oregon has operations and repositories at various locations in Oregon and wishes to acknowledge the traditional homelands of the Kalapuyan people in the Eugene area, Chinook, Clackamas, Kalapuya, Cathlamet, Molalla, Multnomah, Tualatin, and other tribes and bands in the Portland area, and the Coos, Lower Umpqua, and Susla in the Charleston area. I want to thank our sponsors who have generously supported all four talks. They are the Asian Studies Program, the Center for Asian and Pacific Studies, the Center for the Study of Women in Society, the College of Arts and Sciences, the Departments of Anthropology, History, Indigenous Race and Ethnic Studies, Sociology, the Global Health Program, the Global Studies Institute in the Division of Global Engagement, and Oregon Humanities Center's Endowment for Public Outreach in the Arts, Sciences, and Humanities. Thank you to all our sponsors who've made this event possible. I want to thank our speakers, who I'll introduce in a moment, but also the staff at University of Oregon who've been instrumental in making these events possible. They include Kylie Post, Melody Moore, Jacob Box, Morgan Hayward, Ward Biagne, Lori O'Halloran, Dennis Galvan, and there are more I'm sure I've forgotten. Please forgive me, but thank you to all of you. This is the last in this series. There were 4 talks, this being the 4th. Thanks to all of you who've shown up to these talks and made them what they were. The format will be the following. Professor Russell and Wilson will have a conversation on the topic of the conversation today that I read out. This will be followed by questions which can be posted as comments in the chat window or the Q&A window as it appears to yourself. Professor Russell will field those questions as appropriate. And now I get to introduce our speakers. So Professor Yolanda Wilson is an associate professor in the Albert Nagy Center for Healthcare Ethics at St. Louis University, with additional affiliations in the departments of philosophy and African American studies. She earned the PhD in philosophy from University of North Carolina at Chapel Hill, where she was inducted into the Academy of Distinguished Teaching Scholars. Professor Wilson's broad areas of interest in bioethics, social and political philosophy, race theory, and feminist theory. Professor Wilson's work centers on race and gender justice, particularly as it relates to healthcare. Her recent article, Intersectionality in Clinical Medicine, The Need for a Conceptual Framework, is a consideration on applying intersectionality's intellectual approach, how race, gender, and other social identities converge in order to create unique forms of oppression in the clinical environment. a 2009 to 2020 National Humanities Center Fellow, and a 2019 to 2020 Encore Public Voices Fellow, Professor Wilson is currently working on a monograph entitled Black Death, Racial Justice, Priority Setting, and Care at the End of Life, in which she uses the end of life care to argue that given historic and continuing racial injustice leading to African Americans being unfairly burdened with ill health, African Americans have a special justice claim on healthcare. Professor Wilson is the winner of the American Philosophical Association, the APA, Committee's award. I'm sorry, let me read that again. The American Philosophical Association Committee on Public Philosophy Op-Ed Award for her USA Today article, "For Black Shooting Victims, Sometimes Anger, Not Forgiveness, is the Best Response." Her public scholarship on issues of bioethics, race, and gender have appeared in the Hastings Center Bioethics Forum, in The Conversation, among others, and has been republished in outlets such as the Los Angeles Times, the Chicago Tribune, Salon.com, and the Philly Voice. Her article for the Conversation, Why Black Women's Experiences of #MeToo Are Different, was republished internationally and forms the basis for an edited volume on feminist philosophy and #MeToo. Her media appearances include outlets such as National Public Radio, Al Jazeera English, and the Canadian Broadcasting Corporation Radio. Welcome, Professor Wilson. Professor Kamisha Russell is an associate professor in the Department of Philosophy at the University of Oregon and a co-editor of Hypatia, a journal of feminist philosophy. She specializes in bioethics, critical philosophy of race, and feminist philosophy. Her book, The Assisted Reproduction of Race, published by Indiana University Press in 2018, considers the role of the race idea in practices surrounding assisted reproductive technologies and argues for the benefits of thinking race itself as a technology. Other recent publications include Bioethicists Should Be Helping Scientists Think About Race in the Journal of Bioethical Inquiry, published in 2020, as well as On Black Women, In Defense of Transracialism, and Imperial Harm in Hypatia, published in 2019. She's also published Rights Holders or Refugees, Do Gay Men Need Reproductive Justice? In Reproductive Biomedicine and Society Online, which was published in 2018. She is also the 2020-2021 recipient of the Baruch A. Brody Award and Lecture in Bioethicists. Welcome, Professor Russell.
Thank you.
So without any more delay, I'm going to hand it off to Professor Russell and Wilson. And thank you everyone for joining us.
Thanks so much for having us today. I'm excited to have a chat with Yolanda, who gets out a lot more than I do, clearly. Your ideas are spreading widely. Anyway, so for our description today, we read last summer saw the convergence of two major threats to public health: the COVID-19 pandemic and the enduring value gap between white and Black lives, referenced in the name of the protest movement Black Lives Matter. On April 8th, 2021, so just a little over a month ago, the CDC released a statement naming racism as a serious public health threat. By contrast, 6 weeks earlier, the Journal of the American Medical Association released a podcast, which has now been withdrawn, in which the very existence of structural racism in medicine, which is by now a well-proven fact, was called into question. So in this conversation, we want to discuss how the CDC declaration might be translated into action within this larger and social and political context, and what Black feminist bioethics can contribute to the ongoing conversation. So we sort of broke this down into a few questions. And the first one we wanted to sort of speak to was, in what ways does racism constitute a serious public health threat? So what led the CDC to announce it this way? You want to start on that, Yolanda?
I was just thinking, I want to hear what Kamisha has to say about this question first. But I'll start just in thinking about the context, because you always just have amazing things to say. I could just come sit here and just listen to you talk and be perfectly fine with that, just be the one who just kind of fields the questions. But I want to start a little bit thinking about this move, right, by the CDC. I mean, I think this was an incredibly, there's a part of me that wants to say this is a really bold move, right? This is potentially transformative. And then the part of me that is old and cranky and, has been beaten down by life and disappointed enough times, it's kind of like, okay, so what is going to follow from this? And we know that this CDC statement comes after decades of scholars, activists, clinician scholars kind of writing and thinking about racism as a threat to public health and, being marginalized or not being taken seriously or thinking that they're not doing real scholarship. And so it's interesting to me at this moment that the CDC is releasing this kind of statement. However, a whole lot of people have released statements in the past year. And, I was just reading an article, I think 2 days ago on the Root, theroot.com, kind of citing kind of survey data that white people are actually less committed to fighting racism now than before the murder of George Floyd. And so it's going to be kind of interesting to see the kind of statements. Is this going to go the way of, Pride, where, businesses release their rainbows but still their tactics are questionable in terms of how committed they are to promoting justice and creating a just work environment even for people who are queer or who identify, right, who are LGBTQIA plus, and like Susan G. Komen. I mean, even the NFL, they wear pink jerseys in October, but like, what does that mean? So I'm curious whether this is performative or whether we're kind of going to see the beginning of some interesting changes. And given that the CDC is, kind of is explicitly a political entity, I'm curious about what that's going to look like even as administrations change or as time marches on. I don't know, what were you thinking about that?
Yeah, no, I think that, that's always the question. That's the perennial question, right? I mean, so yeah, this is not, it's not news, right? It's not news that that racism is a serious public health threat, but this, is it news that the CDC has said so? I guess is the question. Like, will that make a difference? I did think we could kind of go over some of the ways in which this health threat, why would the CDC say this, and everybody else who said it before the CDC. So I kind of break it down into maybe 3 or 4 things, I think. One, how racism negatively impacts what people like to call the social determinants of health, right? So all the stuff that besides your genetics affects your health outcomes, right? So things like economic stability, the neighborhood you live in, the physical environment you live in, how much food you're able to eat and what sorts of food, right? Whether you have food security and what kind of food you have access to, education, the broader context of your community, and insurance coverage, right? All these are things that are sort of social factors that affect health, right? And so racism actually impacts all of these, both individually and cumulatively, right? So long histories of job discrimination and sort of the prevention of the accumulation of Black wealth and all kinds of forces, right, have created this economic instability among disproportionately minority populations. The long history of racial segregation has really affected the physical environments that people live in, right? And so not only is it separate, but the environments in which people live are not equal. They don't have the same number of parks, clean air, general, public safety, obviously a relationship with the police that is not one that ensures that one feels safe in one's neighborhood. then the food kind of goes along with this, right? You see, fast food and convenience stores, which are, more expensive or less healthy, right, are kind of predominate in a lot of poor neighborhoods, whereas, fresh fruits and vegetables at an affordable price ends up out in the suburbs. Businesses like people, flee inner cities when they're predominantly people of color. They return when those cities become gentrified. And education, we see, the effect of segregation on funding for education, right, in terms of property taxes, is huge. And then, of course, the kinds of education that one is receiving, are also important, and whether whether kids of color see themselves in what's being talked about in history, and if they see themselves as thinkers and doers in the society, or whether they're kind of outside the story, all that that matters. And then obviously health insurance, Blacks are among the least insured in the country as well, for also a variety of reasons, that connect with all the other ones. So we have all these sort of social determinants of health that sort of set people up to be able to, breathe, move, eat good food, do all the kinds of things that kind of set you up for health. All of these are impacted by racism, right? So that's kind of one big thing. But then there's actually, and this to me is the most interesting research actually, is a little more recent, I guess, not that recent, but a little more recent, is the way that repeated experiences of discrimination and collective racial traumas, like, the murder of George Floyd, just over a year ago now, and many other incidents of police violence, these sort of collective racial traumas, the repeated experiences of individual discrimination create toxic levels of stress in Black people that really erode mental and physical health over time, right? So the sort of stress responses that are useful for people in, high pressure situations that actually serve them, when those levels of stress remain at a heightened level for long periods of time, it's extremely damaging to both physical and mental health. And so to recognize that discrimination has been a source of continuous negative toxic stress, right? That means that even without the sort of social determinants, right, that Black people are facing a lot of health challenges that are not a result of some kind of belief in a genetic form of race. So those are sort of like two of them that I think of. And then I also think of the way that racial resentment politically plays out in resistance to things like healthcare reform, to things that would give more access to more people, regardless of their ability to pay for insurance and things like that. So this idea that a government-controlled or single-payer health system or a socialist health system would sort of take the hard-earned money of white people and give it to undeserving poor Black people, right? I think it plays out a lot in the discourses that try to fight various forms of healthcare reform. So anyways, those are some of the ways that I see racism constituting this kind of public health threat. I think they're different, but they're all interrelated.
Yeah, so I think kind of just to add to some of the things that you've already said, I think that sometimes there's this tendency to lump all, to just imagine Black people as existing in this kind of space of unrelenting poverty. And while it is the case that we are disproportionately poor for a variety of reasons, including the reasons that you've listed, right? I think that sometimes the conversation turns to this kind of individual responsibility and, if we just kind of mentored an individual Black person here and there, everything would get fixed, right? It would be fine. And I think that what's also important about this statement about just structural racism, structural inequality, is the recognition that racism operates in our lives regardless of class, regardless of income, regardless of educational attainment, that it's not just this kind of punishment for being deviant, right? And that's where some of the racial resentment conversations and assumptions are, right? If Black people would just stop being criminal, then all these other problems would go away, right? And there are really interesting numbers. We see a lot in the kind of maternal fetal health numbers around how across class, across insurance status, across educational attainment, that Black women have much poorer outcomes. Black women and Black babies have much poorer outcomes that can be attributed to racism, to the kind of broader context of existing in an environment of racial stress, but also within the clinical encounter. And I think that those become very important pieces to talk about structural racism. Even the wealth piece, it's really interesting that even high income Black people, just kind of as a community, as a collective, our wealth tends to transfer backwards, not forwards. What do I mean by that? Well, that we are more likely to help elders and help others in the family, right? Once we become highly educated, high income people. So again, we can critique capitalism, and I think we absolutely should. But while we are literally existing in a capitalist structure and a capitalist schema, I think we have to talk about what that really looks like and how that works. And how that works is that, educational attainment and having high incomes don't provide the same opportunity for Black people to accumulate wealth for lots of reasons, housing discrimination, et cetera, but also this kind of transferring of wealth backwards and out to our families who may not have the same kind of income and educational attainment. And so I kind of want to think about, there's a lot of conversation about kind of social determinants of health and a lot of big words that we talk about and we know what we mean, but I like to think about also what does that look like on the ground? Because I think there's kind of a disconnect with some people, even people who do this work, about what does that really mean to say that, houses in neighborhoods that are predominantly Black are undervalued. What does that mean on the ground? Well, it means if you get sick, you don't have the equity to pull out of your house that some others might, that white people might have. It means that, when you go to sell your house and you want to move up, so to speak, you don't have the same kind of down payment, right? It means lots of things. So I just want to stop there and just make those kind of additions to.
No, thank you. And I feel like, the wealth thing too, I mean, I've been reading a lot about Black history recently, and I'm also struck by the way that Black wealth is sort of literally stolen and destroyed, like over time. I mean, and sometimes in really almost unbelievable ways, right? Like, something like the Tulsa bombing, right? I mean, like, so not even just like subtly, but, like by bombing a Black neighborhood in Tulsa that is prosperous, you're just sort of literally taking away the efforts, of those people, right? And the wealth that they would have passed on to their family and children, right? And so, I mean, yeah, so I feel like when we think about, and I think this connects, well with your reminder about, sort of it not being the case that Black people are into sort of this nebulous space of unending poverty, which does then sort of seem like somehow it's their fault, right? To really kind of see that, again and again, Black people have worked hard according to the existing rules in the country to gain, sort of wealth and health and general forms of security and happiness, and actually had those actively taken away. And I think that the undervaluing of the houses is also a really crucial example, right? So that if you do the exact same thing that a white family is supposed to do, which is to say buy a house in a neighborhood where you can and wait for that house to gain value, so you gain equity and have that kind of wealth and security, right? That for white people that will materialize in white neighborhoods that are highly valued, right? And it will just not ever materialize, right? Because and again, not due to anything that that Black people are doing, right? I mean, it's not saying that Black people should always follow the rules of the society, but even when they do, yeah. So I feel like we want. Go ahead.
Oh, I'm sorry. Like, I know that this isn't a conversation about wealth, but I think it becomes so important because I think that it's connected to kind of how you and I both work in kind of race and bioethics that I think maybe some other bioethicists don't always think about it in these really explicit ways. And so, two more kinds of examples, we talk about the stroke belt, right, in the rural South, which literally geographically follows the Black Belt, which has very clear historic ties to the import of slaves and the Cotton Belt. The Cotton Belt is literally the Black Belt. If you overlay the Black Belt, the Cotton Belt, the Stroke Belt on a map of the US, you're literally looking at the same geographic space going north to maybe Virginia and headed, down south across to maybe the Mississippi River to Mississippi. And we think about Black rural health, right? I'm from a rural space, but one of these kind of discussions about Black wealth that I don't think we have often enough is about Black farmland, right? That so many of us had farmland and other kinds of, smaller farms, big farms that were, downright taken in ways that Tulsa, but also the ways that the law codifies, for example, limits on air property. And I know indigenous communities have suffered land loss for these similar kinds of ways of families just having land and informally passing it down through the community and through the family. And, the state governments, literally intervening and limiting air property. So there are fights happening right now in the kind of Gullah Geechee communities of South Carolina and Georgia, where people want golf courses on the beach now, and this land that was undesirable, people are losing now. And second, I was thinking about what you were saying about playing by the rules, right? There's always this, if Black people just tried harder, played by the rules more, we could get more. And, the glaring example that always pops into my mind is access to VA loans that were systematically denied Black veterans who have disproportionately participated in and served in the military. Now we can talk about, the military, like this becomes a complicated story, right? Black military service as a vehicle for kind of proving our worth and worthiness of citizenship and full citizenship and access to all of these things, while at the same time having the kind of tensions and complications of participating in the imperialist project. But to come home and not have access to VA loans, right, as another kind of way that housing is just systematically denied. And I want to say she's a sociologist. I can't remember her discipline, but Professor Caretha Mitchell has deemed these kind of behaviors as know your place aggression, right? These kind of direct responses to Black strivings. And I think that becomes important for this conversation that we're kind of growing to have, but also in these other kinds of ways of like housing and access to health and clean food and water and such. That is not accidental.
I feel like I also now want to go like totally far afield, which is not really, but I also think about, after emancipation, right? Like there's also this sort of idea that there was just sort of this mass of ignorant and unskilled people that just kind of were left there. If you even remember that they were left there after the Civil War at all, that there were 4 million people. But also the like, oh, sorry, then I lost my train of thought. So Black people came out of slavery actually with a lot of skills, right? With a lot of farming skills, a lot of agricultural skills, a lot of, blacksmithing and other,
masonry.
Yeah, exactly. Carpentry. I mean, all, so to sort of think about how, again, this idea that somehow there was just sort of a bunch of sort of lazy, shiftless people that got kind of released into society, and when in fact, there were many skilled people and many people who were skilled when they were brought here in cultivation from Africa, right? Like, so, it's just, if there's such I feel like this whole sort of compounded myth about how Black people have ended up where they are today, and these repeated very similar cycles of of blame and sort of disinheritance are really important to all of this. And I feel like that's, and maybe to sort of skip ahead to one of our sort of later questions, I think this idea of this sort of historical memory and its continuing influence is one that Black feminism has always taken seriously and really so I think that sort of perspective on things is something I think Black feminism can really bring well to the conversation, where history is always also present especially for Black people in the US. But so I guess I'll try to move us forward in some sense. So what about, why do we think that doctors are resistant to the idea of structural racism in medicine? Like, why this podcast, right? Right before the CDC is about to, dignify all the years of research by agreeing that racism is a public health issue.
Mhm. So one thing that I would say, I mean, I know that you have, I think that our views are similar on this one also, but one thing that I say just about that podcast itself, right, about the JAMA podcast, JAMA is one of the most prestigious medical journals in the country, if not the world, right? And that they have this podcast now, and the kind of editorial board kind of connected to the journal, and some journals are moving in that direction. I'm seeing that more now. In fact, I was on a podcast earlier today for JBI, Journal of Bioethical Inquiry. But one thing that says to me, just kind of pulling out and taking a kind of bird's eye view of how that all went down, is that even in the most prestigious spaces, right, of medical education, of cutting edge medical research, it's telling that one can exhibit a stunning level of ignorance about race and racism, and still be an expert who runs around treating people of color, right? So this is, I don't want to get on my education soapbox, but it is really telling that in our kind of medical education space, and I use that very broadly, physicians, nurses, nursing assistants, right, bioethicists, everyone, that one can be a legitimate, credible person in one's field or discipline, never having seriously studied racism, never having seriously thought about feminist bioethics, never having seriously studied disability ethics, and can be invited into the most kind of illustrious spaces to spew one's ignorance. And it's only when there's a backlash, right, that you're called on the carpet. I think that says a lot about the state that we're in terms of US healthcare, right? That in itself, the fact that it happened, says some really interesting things to me that are even more interesting than what the physicians themselves had to say or why they may have said it. But I think that it says a lot about education and who's valued and whose thoughts are important. I mean, I could imagine that we're epidemiologists, Kamisha, right? I mean, we're not expected to, right? I mean, we would, there would be an expectation that we are experts in things that do or should matter epidemiologically in the literature, right? And in my mind, thinking about race and racism and how kind of disease spread, right, factors of racism, how they shape disease spread, that seems like that's an important thing to know. And that you could get in JAMA and not know anything and deny what is now 50 years of scholarship specifically on structural racism, called structural racism. We know Du Bois is talking about this stuff in the early 1900s, but kind of current literature that we're using the fancy, models and language. That's 40, 50 years of scholarship right there. And to just not know it and not care that you don't know it and just situate yourself in your ignorance is fascinating to me. Not surprising. I don't know if it's even fascinating, but it's interesting.
Yeah, no, I think it's exactly right. And I mean, maybe this kind of connects to how medicine sees itself as this sort of science, and it probably, I think it connects as well to the lack of attention that's been paid for a long time to these sort of, social, the reason social determinants of health is a buzzword or whatever is because of how little attention medicine paid to that for, during a particular period of the sort of rise of scientific medicine. So I mean, I think, yeah, I feel like that's a part of it, right? That already they're just supposed to learn about kind of the workings of the interior body, right, without sort of attention to the whole person. And then on top of that, right, the sort of facilitated ignorance of social relations and in race relations and interactions, right, sort of just all combines to allow you to be really good at knowing the parts inside a body, and yet have sort of no idea of the interaction of race with other social factors and the strong influence of those on actually the physical body on which you're supposed to be an expert, right? So I mean, I do think it is striking across so many professions and disciplines, how little knowledge of racism and its effects on those professions and the people those professions serve is considered a qualification for that work. Yeah, I mean, and
I like one other thing that you. Oh, I'm sorry. I didn't
no,
mean
go
to
for it.
interrupt.
Yeah.
Now, I was going to say one other thing that kind of talked about in the preliminary document, right, is this idea of being attached to racial innocence. And I'm curious what you have to say about that. I didn't want this question to pass without us talking about racial innocence and how that derails actually efforts to bring about racial justice.
Yeah, no, I mean, I think, I've been reading a lot of stuff about that as well recently. But I mean, I think, especially if you think about sort of medical professionals, right? I mean, I think there's a sort of self-perception of being, first of all, very rational, but also very committed to helping people. I mean, just basically being a good person, right? I mean, you would expect, if you're on, if it's not COVID and you're on a plane and you're chatting with your neighbor or something like that, and you say, oh, I'm a doctor, that they'd be like, wow, it's amazing that, you know all these things and you help people. So I think there's, sort of an idea about doctors as highly educated, really helpful, aware, just sort of having a calling, right? That all sort of, leads to this idea that how would a doctor, aside from somehow a sort of avowedly racist doctor, right? But how would a doctor who doesn't think of themselves as avowedly racist, how could that person possibly be complicit or even responsible for poor treatment outcomes for Black people, right? So I feel like there's this, I think it's human to want to think well of yourself and your aims and what you do. And so I do think there's that resistance, especially in the US, because it is such a deep history and it goes so deep and it's so interconnected. I think there is this desire, Baldwin talks about this a lot, James Baldwin, like this real psychic need to not recognize how bad everything that happened in terms of race in the US was and how foundational to the US it was. There's just, it's so bad that, that the people don't want, they almost just can't even let that in. And still sort of maintain a good perception of yourself. So I think that, doctors, like everybody, want to think they're good people, but in particular, they want to think they're knowledgeable people and that they're above irrational things like racism and that they just want to help everybody and all this kind of stuff. So I think that, that's sort of the innocence, particular, I guess, the medical profession that I was sort of had in mind. So then we, and I guess, as I think we're, going on perhaps a bit. So
I'm kind of semi-watching the Q&A, so just to make sure. I know you're watching it too.
Yeah.
But
I think we can also try to, we start off this idea of how can this statement be translated into action, which I think is always the hardest question. So therefore I'd love to just stick on the other questions and not go to this one, but I think I think we probably should try. So what do we think? What would be the response and the taking up of the statement that would actually make the fact that the CDC popped up to make this statement, kind of a real important moment in the whole conversation? Like what could come of this that would sort of really make that matter?
Right. Well, I think, a step, not the only step, and is, I guess, kind of what we alluded to in the JAMA conversation, right? That part of medical education, right? If the CDC is going to take the position that this is important, right? That racism, the experience of structural racism, is a public health threat, then those who we are training to enter healthcare spaces have to understand something about structural racism. And so I think that's one obvious key, but it has to be done in a way that respects the scholarship and the intellectual genealogy. And so kind of skipping to this one and the kind of Black feminist bioethics too, right? There's this way I think that Black feminists think about intellectual genealogy, think about organizing even outside of the academy and contributions to scholarship. What I don't want to see happen is a bunch of people kind of taking up race all of a sudden and doing it poorly and ignoring the kind of generations of marginalized scholarship, whether it was in the academy or out of the academy, in order to take this seriously, because then you're just kind of reifying the same kinds of power dynamics that have contributed to the problem of structural racism. And that will become the sad irony of this CDC statement. And then the second thing I would say is, our institutions have to be willing to draw lines in the sand, right? I mean, we still have conversations about, patients coming in and saying, I don't want to be treated by that Black nurse, right? I don't want that Black nurse touching my baby, or I don't want that Arab, because everybody vaguely brown who doesn't speak Spanish is right. Doctor touching me, and I think that our institutions have to kind of draw these lines and be very clear about it. And then the third thing I would say before I kind of turn this over, is kind of connected to the second, is we have to stop coddling white people. And by that, I mean, right, I think sometimes in these conversations about structural racism, in these kind of attempts to address, sometimes the room turns into reassuring white people that they're good and that they're nice and that they're not racist. And I think that's a problem. That we need to be able to say, look, you can't suck all the air out of the room right now, right? This conversation isn't about whether you personally are racist. And most of us actually don't care, if you really ask deep, right? That we have this other issue that we need to address, or these other set of issues that have life and death consequences on the ground, and kind of related to that, not just in our kind of individual and institutional spaces, but one thing that drove me to consternate, oh my God, was the New York Times, which they irritate me for lots of reasons. But I remember early in the Trump administration, right, when Trump was kind of rolling back and fueled with racial resentment, as you talked about earlier, or at least had promised to kind of roll back some social services, including some healthcare services. The New York Times just published all of these articles about sad white people and, poor white people in the South and poor white people in the Midwest, who themselves were, making use of Medicaid, and who relied on Meals on Wheels. And, they're always staring forlornly out the window, and their faces always kind of in silhouette. And they're always saying, and they regularly, I mean, you only needed one or two of these. You didn't need a whole series, right? I thought that they would just take from the Black people. Right? Why are we giving this airtime? Why is this getting column space in the New York Times? Again, centering kind of how white people feel about things. I think Biden is going down the same line of, kind of resisting making bold moves in response to, sometimes not even response to, in anticipation of a kind of racial resentment. And I think if the CDC statement is going to have teeth, and we're going to take the CDC seriously, I'll be curious if NIH releases a similar statement, right? What are the government's leading health agencies going to do, and what is that going to look like for Black people going forward?
Yeah, no, I think that's really, yeah, like, I mean, I think part of what the sort of interconnection with the social determinants of health and insurance coverage and clinical encounters. I mean, I think the way that all of this comes together too really suggests that it is the sort of bold rethinking that is called for, that kind of one change isn't going to, or even a few changes aren't really going to do it. So I think that it makes a lot of sense to me. And like you said, the training, I mean, the med school, and not just med school, but like all kind of places that train health professionals, all the sort of, continuing education training that medical professionals are always having to do. All of these places could be spots to really bring this missing education to the forefront. And I really liked your point about, not sort of having white people take up race without, intellectually, without sort of this intellectual genealogy. And I feel like it's a move. And actually, I think often these sort of, at least in philosophy, if you sort of add the words like social in front of something, like social epistemology or, whatever, it often means that you sort of take insights from marginalized people about these issues and admit that they really exist and that we're not just kind of in an idealized kind of world, right? And so I could definitely see people kind of taking up the insights, uncredited, taking the insights of, sort of years of scholarship by Black men and women and gender non-binary people, and sort of saying like, oh, we've discovered that this matters, like we figured it out and now we're going to give it to you, so I agree that we don't want to see that happen. But I mean, I also think about sort of, institutional norms. So I think, we think about norms a lot when we think about structural racism. And I think there's sort of these really broad kind of norms in medicine that are really problematic, but also, just sort of in a particular place, like if it's a hospital or a clinic or whatever, right, there can be norms, right, that and they can be enforced by people who, just by, sort of social approbation, really, just like, there are places where you can steal someone's lunch out of the fridge and there's places where you can't, right? Like, because the norms are there, right? So, I mean, I feel like, we probably need to, what people probably need to do individually, right? So at the individual level is really start to create and work with others in their institutions, in their sort of really local institutions, to set up norms that don't allow for, sort of the perpetuation of racist stereotypes or, talking about non-white patients in particular ways, or, I mean, just a variety of kinds of things that might sort of go unnoticed. I think, if the norm were really about like, hey, we want to really provide good healthcare for a lot of people, from a lot of different places, and we want to figure out all the ways to do that, and that's what it's going to be a good doctor here, a good nurse here, a good tech here, or a good admin here, right? Like, I think that could kind of, I think that could also go a long way and kind of gets away from this sort of overwhelmingness of the idea of structural racism. Like if you sort of tell white people about structural racism and they actually listen and then they get it and then they're like, whoa, and then it just like they're sort of frozen with the feeling that they can't do anything because everything is so awful. Meanwhile, everything's been awful for a really long time and Black people still do things. So, I mean, I feel like if we can really kind of think about, okay, well, what kind of place are you going to work in, and how are you going to affect that place that you work in, and what kind of things are you going to accept from yourself and from others? And I mean, I think there is a way, I think, to not sort of seek the reassurance, not seek the return to innocence, but really seek to be active in one's particular institutional role. And I think this is really important for professionals, because professionals, even kind of all along the way, have a lot of autonomy relative to non-professionals, like in sort of workplaces and things. So I think they really have the power to kind of set norms for how doctors, nurses, techs act in the space, right? And so I think what that professional power should be used toward anti-racism, and instead of kind of defending or shielding oneself, it should really be about like, okay, let me kind of go in and try to be better and try to ask people around me to be better and learn things and keep learning and keep doing. I mean, I think a lot about the term praxis, right? This idea of sort of theoretical reflection and action that happen cyclically and at the same time, so that you're never sitting back because you read 100 books on racism before you're allowed to do anything, nor are you just kind of deciding you must know, you can just kind of divine from your heart and mind what the right thing is to do and just kind of go in there and do it as if no one's ever thought about this before. So I've got that sort of combination of learning and trying and experimenting and receiving feedback and doing more learning, and kind of together is really important to sort of stop this urge to inaction in the face of a really large problem, whose magnitude I think does need to be faced. But again, I don't want people to take in the magnitude and then just kind of freeze, like, okay, well, guess it's all beyond me, right? So that's what I've been
and I think of praxis as part of our Black feminist inheritance, right?
Exactly. Yes,
thinking
very
about
much so.
Yeah.
Good. So I think we're progressing here, and I see there's a question
in the Q&A. Yeah.
So I'll read the question from Kristen Yaris. Well, it's not everything. There's quite a lot of mobilizing in local public health communities right now, spearheaded by the American Public Health Association to push for local legislation declaring racism a public health crisis. Multnomah and Lane counties, which is Portland and here in Eugene, were 1 and 2 in Oregon in passing such laws this spring, or declarations this spring. Now HB 2337 is pending in the Oregon legislature. I think these bills themselves are not solutions or endpoints, but the intersectional activism led by public health activists of color, for me, offers a lot of promise in terms of seeing these bills play out in ways that positively impact our communities through ongoing activism. I also think it's important to remember the historical antagonism between public health and medicine. So public health is moving quite progressively, while medicine and the AMA may not be. Yeah, I think that all of that, and I think that actually points to a sort of different kind of dialectic of praxis, right? The sort of legislating and the activism, and that sort of sort of doing stuff on the ground in communities, and then also working for legislation that will encourage other communities, and kind of that constant sort of organizing. And I think, like Kristen said, and you just said, that is a hallmark of Black feminist activism as well. So what else?
There's something else in the Q&A.
Kristen said
Kristen just said thank you.
Yeah.
Okay.
You're welcome, Kristen. Thank you. So what else do you want to say about maybe Black feminist bioethics and what it can contribute before we run out of time? It's one thing so actually I often think, when I want to think about sort of what Black feminism brings to issues, bioethical issues, I often think about the reproductive justice movement. I sort of see it as an exemplar of what women of color and Black feminists can do around an issue. In this case, around the sort of idea of reproductive rights, where not only, so where part of it was pushing at what is included in the idea of reproductive rights, like sort of, pushing to include the right to have children as well as the right to an abortion, and then further to the right to raise children in healthy environments, right? And to have the ability to do so. So I think, I feel like one of the things that Black feminism does is look at the experiences of Black women and other marginalized people, and really try to open up issues that have been maybe conceived pretty narrowly. So I think that's kind of one way to kind of open up, this, to take the CDC stuff and really think about it and really make it kind of broad and comprehensive. Another one is coalitional politics, right? Sort of bringing together different groups, around issues, so for reproductive justice movement, a lot of different women of color groups have faced a lot of different forms of reproductive justice over time. Certainly Native Indigenous women, Chicana women, Puerto Rican women, Black women. There's just, there's all kinds of horrible eras of abusive sterilizations and other issues. which are ongoing, frankly. But so I also think about that sort of ability to bring a lot of people together to fight, again, on the ground and in theory and in academia and all the places.
Mm-hmm, mm-hmm. Yeah, I mean, when I think about Black feminists, right, I think about a couple of things, right? Black feminists, right, as people, as a collective, as and even thinking about Black feminist theory. One thing I think about it, and this is probably connected to what you've said, is our ability to hold multiple thoughts in our head at once. And what do I mean by that? I don't just mean intersectionality, which is an important contribution of Black feminist theory, which, again, if you're thinking about the intellectual genealogy, Black women are thinking about this in the 19th century even. But just this idea of, look, we can struggle against racism and think about sexism, and it doesn't demit, right? There's not a kind of this is it. It's not a zero-sum game, right? That kind of fundamental to the kind of Black feminist orientation in the world is, if the least among us win, we all win. And I think that, a lot of activist spaces, there's this kind of jockeying, or there's this sense of life as being zero sum. And so if I care about this thing that's happening to you, then somehow that takes away from the injustice that's happening to me. And so one thing that I think is a really important Black feminist contribution to the intellectual work in general, but also in bioethics, is this kind of ability to hold these things together and see them as kind of interconnectedly a struggle for justice. And since justice is one of the foundational principles of bioethics, I think that it's important to I think that this worldview becomes important as the field, if the field moves more to thinking more about justice in these broader ways. How does that happen, right? Because I think the dominant narrative is a kind of zero-sum framework. And so I think that that's going to be a really important lesson from Black feminists.
Yeah, I mean, now I'm thinking about your series of New York Times pieces and the sad white person gazing off out the window, right? I mean, what if all of those pieces had it more as their theme? It's not a zero-sum game, right? Like, what if it had been, what they had sought out, multiracial coalitions of people trying to improve, fill in health gaps in their localities, and and help each other and make things better for, I mean, what if that had sort of been the narrative that they had really pushed in response to the kinds of rolling back that Trump was doing or trying to do? Like, it would be a really different way of thinking about the whole thing, right? Not in terms of winners and losers, but in terms of sort of mutual dependence and the idea that we kind of rise and fall together. It would be a really, and it wouldn't make everything perfect, but it would certainly frame the narrative, I think, in a much different way. And it would require a different picture than a sole person, looking off into the distance,
Right. And it orients your work differently.
Yeah.
Right. If your starting point is we rise and fall together, versus if that person gets something, then I've lost something. Yeah. You move differently, you think differently, your activism is differently, your scholarship is different and better, I think, in lots of ways.
I guess we can invite anyone who is waiting till the end for questions. I think it's a really lovely place to stop. To think about moving differently with a different orientation towards justice and how there could be enough to go around. I don't see anything, so I'm thinking maybe at about an hour now, it's about time for us to sign off.
Yeah.
Okay. So
thank you so much, Yolanda.
No, I'm just so excited that you invited me to have this conversation with you, Kamisha. I always love talking to you.
I'm excited you said yes.
Yeah.
as you can imagine, I was very excited that you both said yes, because we couldn't have the event without both of you. So thank you both. That was a very engaging and interesting discussion, and it ended on a hopeful note, which is a difficult thing for all of us people of color living, but also when it comes to health and politics. So that's a hard thing. That's a hard note to land on, a good one, especially in these times. So thank you both extra for that. What I'd like to do is thank everyone for joining us for this and all the other conversation in our series talks. They've all been recorded, and in about a week's time, this conversation will also, the recording will appear on the website. And I think Kylie is posting in the chat the URL for where you can see, yeah, or if you want to watch again or use in your classes or seminars or workshops or whatever, any of the conversations about our world talks. And please use the website, use the recordings. They're there as tools for thought, for learning, and hopefully for progress with a small p. Thank you everyone for joining us. Thank you, Professors Wilson and Russell, and wish everyone safety and good health.
Thank you.